Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to today's milestone in our journey of 52 weeks of Diabetes Essentials, Dr. Sanjay Kalrasa. These online modules are an educational initiative from Enerzal Zero and in memory of Dr. K.K. Garwal sir. Dear viewers, India has an estimated 69 million people suffering from diabetes with a prevalence of 8% in general population. More than 5 lakh cases of tuberculosis can be attributed to diabetes. Diabetes increases the risk of developing TB by nearly 2 to 3 times. Moreover, diabetes can worsen the clinical course of TB, and TB can worsen glycemic control in people with diabetes. Also, diabetes worsens TB treatment outcomes in terms of increased death, failure, and relapse rates. So, before I hand over the platform to Dr. Kalra sir to take us through today's module, let me have the opportunity of announcing the names who have answered the quiz questions correctly on the MedTalks platform declared in last week. And the names are Dr. Sri Prakash Pandey from Chhattisgarh, Dr. Sumita Sharma from Delhi, Dr. Dhirendra Sanindia from Gujarat, Dr. Gautam Datta from Jharkhand, Dr. Anupama Swamy and Dr. Putta Somappa Shambulingappa from Karnataka, Dr. Ravi Bhatt from Karnataka, Dr. Hira Daldoria from Madhya Pradesh, Dr. R.L. Taneja, Dr. Namrata Puri, Dr. Sanjeev Puri from Punjab. From Maharashtra, we have a big group: Dr. Ashidwar Pawar, Dr. Anupam Agarwal, Dr. Dharmika Tandon, Dr. Girish Kesota, Dr. Pratap Parkar, Dr. Harsh Shah, Dr. Jagruti Dabuwala, Dr. Kulbhushan Tandon, Dr. Manisha Dinge, Dr. Nariman Doctor, Dr. Pramod Umarji, Dr. Sanjeev Desai, Dr. Seema Shah, Dr. Suman Agarwal. From Uttar Pradesh, we have Dr. Ashwini Kumar, Dr. Irfanullah, Dr. Sanjay Mehrotra, and from West Bengal, we have Dr. Ashutosh Das, Dr. Santanu Kumar Bhattacharya. And with this, I hand over the platform to Dr. Sanjay Kalra, sir. Sir, over to you.
Thank you, Rahul, and good evening, everybody. Today is a special day in our discussion on diabetes essentials. And the reason is that for a change, we'll be focusing on something that is so frequent in our practice and something that is not related to vascular complications. Earlier, about 20 years plus ago, we used to treat diabetes from a glucocentric point of view, just bothering about the glucose control, whether we are having a good fasting, a good postprandial, and a good HbA1c. That was a mistake. That was an error of omission. We corrected that partly. But if you see the discourse over the past 5 to 10 years, we have entered another tunnel vision, and that is that of viewing diabetes as a vascular disease. So we always talk of diabetes as a vascular disease now, and we are always talking of cardiovascular disease, cardiovascular health. At least improvement has taken place. After focusing only on the coronary arteries, discourse expanded to include heart failure and renal disease, and now we view the patient as a whole. But most of the guidelines that we read and most of the literature that we read comes from the West. And therefore, the Western opinion leaders and the Western doctors will focus on diseases that they see. In India, however, in our practice, in your practice and mine, infectious diseases are very common. So, when we see patients with belanoposthitis or pruritus vulvae, that is their chief complaint. If we see patients with a foot ulcer or soft tissue and skin infection, that is the chief complaint. And if we see patients with pneumonitis or tuberculosis, that is the chief complaint that we have to handle. To understand this, it is important to look at Indian data, Indian studies, and also to share Indian experience. And today I would like to acknowledge Professor Jubin Jacob from Christian Medical College, Ludhiana, Punjab, from whose articles the following slides have been taken. Professor Jubin Jacob is an expert in tuberculosis and diabetes. He's an endocrinologist. And what he tells us is what we already know, that in a high risk country like India, diabetes is increasing very fast, but tuberculosis is not going away. In fact, in persons with diabetes, there is a 2 to 4 times greater risk of having active tuberculosis. And the risk of diabetes in persons with tuberculosis is the tune of one third. 30% of all people with tuberculosis are likely to have diabetes. So, actually, when you see our national guidelines, they recommend screening for diabetes twice, once when ATT is started, and once a few months after ATT is started. The double burden is so huge that our national planning, our national planners, policymakers have made it a point to ask for glucose monitoring twice during the course of ATT. Diabetes is an immune deficiency syndrome, especially uncontrolled diabetes. And because of this immune deficiency, sometimes latent tuberculosis may get reactivated. And because cell mediated immunity is impaired in diabetes, tuberculosis responds poorly to anti-tubercular therapy. And this response worsens if glycemic control is suboptimal. Various factors lead to tuberculosis. We are all aware of the overcrowding and lack of ventilation, lack of sanitation that we see in many parts of the country. Indoor pollution and the fact that we had to remain indoors for long periods of time because of COVID, that has led to increased risk of progression of tuberculosis. Substance abuse also plays an important role in tubercular outcomes. And still, in spite of all that we do, all that we say, there are many barriers to healthcare access. The government is doing a very good job through the national programs of providing free ATT to our patients, but we need to do more. One of the ways in which we can do more as healthcare professionals is to understand the syndemic of TB and diabetes. This is potentially lethal. So, basically, what it means for us is that if you have a person with diabetes, especially uncontrolled diabetes, do think of tuberculosis. Get the screening test done. We know what those tests are: a chest x ray if there is cough for more than 3 weeks, maybe a simple ESR, a complete hemogram. If there is a cough, you send a sputum test for AFB. Anyone with uncontrolled diabetes and no other obvious cause should be screened for tuberculosis. Of course, if there is an obvious cause that is staring at you in the face, the common ones in my practice are foot ulcer, skin and soft tissue infection, and melanoposthitis and pruritus vulvae. If none of these are there, then think of the chest. On the other hand, if you have a person with tuberculosis, do screen for diabetes, take a good history, and do the tests, a fasting, a post-load, and HbA1c. And especially if your patient is not responding properly to tuberculosis, then screen more aggressively for diabetes. Sometimes you will see that your patients are in starvation ketosis. The patient has tuberculosis, the patient is so catabolic, patient is not able to eat properly. So you will find that the glucose is low or maybe just borderline. But do your urine ketone and you will find that large. That can be starvation ketosis, it can be diabetic ketosis, it can be a mix of both. How do we explain to our patient? So, what I tell them here in my practice is that alcohol and sugar both come from the same plant, from the sugarcane plant. Supposing you do not harvest the sugarcane on time, what will happen? Within the sugarcane, sugar will begin to ferment. It will get converted into alcohol. When this happens, the sugarcane is not fit for sale because the sugar mill person who is buying the sugarcane, he will test for sugar and he will say, your sugarcane crop doesn't have enough sugar in it. I'm not going to buy it. Same thing happens in our laboratory. If we have a person with hyperglycemia, that's fine. Our glucose machine will pick up the hyperglycemia. But if the patient has high glucose plus ketosis, ketonuria, some of the sugar, 100, 150, 200, we don't know how much, will get converted into ketones or alcohol. This is how we explain in the OPD. So instead of a 400 glucose, you will end up with a value of 200. And that is a sign of false relief. It will actually take you up the wrong path. So you must check urine ketones in every catabolic patient. Please remember to do that. If you have ketonuria, then you assess for ketoacidosis. Clinically, fast pulse, fast respiratory rate, thready pulse, and use of accessory muscles of respiration. If you suspect acidosis clinically, then ideally a pH should be done. An arterial blood gas should be done. Even if there is no acidosis, that means the patient has ketosis or ketonuria, and the treatment of choice here will be insulin. If you give a drug like metformin or SGLT2 inhibitor, you will end up worsening the patient. Once we have understood this bidirectional relationship, it becomes easy to move ahead. And we can tell our patient actually what we say is that diabetes, of course, may have led to tuberculosis, but now that is done. We cannot cry over spilt milk. Let us talk about the future. Let us control your diabetes. When we control your diabetes, not only are we giving you a good glucose number, not only are we giving you good appetite, good health, but we are also improving your immunity. Most patients understand the concept of immunity. You tell them that there are cells in our body, koshika in English, which will help you fight the disease. The same way that those cells fight COVID. So here, how can we help those cells fight COVID? And how can we help them fight tuberculosis? By good control of diabetes and also with good nutrition. Here in Haryana, people may not understand red blood cells and white blood cells, but they understand lal koshikaएं and safed koshikaएं. And platelets is something that everybody understands. So whether you say platelet in English or plate in Hindi or pleta in Punjabi, people will understand that. So you say that just the platelets will get improved if you control diabetes properly, and that will help fight tuberculosis. Now, in a busy OPD, how can you differentiate between diabetic patients with tuberculosis and the non-diabetic patients with tuberculosis? There are actually subtle differences in manifestation. So, first of all, persons with diabetes will have a more stormy course, more fever, more chances of hemoptysis. They will come in with uh, a more symptomatic state. They will also be more catabolic, lean and thin with history of weight loss. You will find that they have malnutrition. So go back to your MBBS days. What are the symptoms and what are the signs of protein energy malnutrition? What are the symptoms and signs of micronutrient malnutrition? Vitamin deficiency, mineral deficiency. You will find those in this population. Look at the hair, touch the skin, see the nails, and you will find malnutrition. When you do an X-ray, persons with diabetes will have a greater than normal chance of having lung cavities and also diffuse parenchymal lesions. Especially lower limb involvement is more common in persons with diabetes, as opposed to non-diabetic patients who have upper limb involvement. We have to be aware of atypical presentations. For example, positive radiography, but negative sputum examination. So be aware of this. Discuss with the colleagues in the laboratory. Get the sputum AFB done again and again. And on clinical suspicion, do start the ATT properly. Also remember that there are rules now. If you are starting anti-tubercular therapy, it is a notifiable disease and you have to notify your uh, district chief medical officer. So follow the rules in your district. So there is a difference in clinical presentation. There is a difference in radiology. There is a difference in microbiology because you will get less sputum positive patients. And there is unfortunately also a difference in treatment outcome because persons with tuberculosis and diabetes are more likely to have multi-drug resistant TB and also unfortunately more likely to succumb to the disease. Like we said, we must screen both people with tuberculosis and people with diabetes for the opposing disease, especially if the tuberculosis is uncontrolled or atypical, and especially if diabetes is uncontrolled. Treatment in general is the same for tuberculosis. Uh, you will start with directly observed therapy. In newly detected patients, 2 months of intensive phase with four drugs. And the four drugs that are used across the country are INH, uh, INH, rifampicin, pyrazinamide, and ethambutol. HRZD, sorry. Multi-drug resistant tuberculosis will be treated as per guidelines. And linezolid is a drug that is being used quite frequently now. But what about diabetes therapy in tuberculosis? Now, this will depend upon the patient's body weight and the body mass index. But remember that the patient is in a catabolic state. So do not reduce total calories. In fact, you have to ensure that the patient takes adequate nutrition, especially adequate proteins. Suggest a 3 plus 3 meal pattern. Small frequent meals which the patient can take. The first 2 weeks or so, appetite will also be limited. So ask the patient to take small frequent meals, take whatever he or she wants. Restrict the fats, but do not restrict anything else, and encourage the patient to take high quality protein. Most patients will accept eggs, which are quite economical as well. If the patient is non vegetarian, let them increase fish and chicken. Within chicken, you can tell them that the leg piece has more of fat, the breast piece has more of protein. So let the patient take the breast piece, and the children in the family can enjoy the leg piece. If fish and chicken are not available, the next option will be mutton and liver. If the patient is vegetarian, then there are two good sources of protein. The first is dairy products. So, milk, yogurt, buttermilk. The Hindi for buttermilk is lassi or chaj, and cottage paneer, cottage cheese. These should be increased. And the second would be dals like black chana, safed or white chana, and rajma. In these, the maximum protein content will be found in white gram and black gram. But even better than them is soya bean. Soya bean has the second highest content of protein in all the Indian vegetarian foods. The first prize for highest protein content goes to a dal known as bhatki dal. Bhatki dal, the English word is black soya bean, and this comes from Uttarakhand state. So try to source that for yourself and encourage your patients to try that if they are able to get it. But do try it yourself. It is a very wholesome source of protein. And cook the dal and let us know next time how it tastes. Bhatki dal, you will be able to source it online. It is grown in the hills of Uttarakhand. Now, for anti-diabetes therapy, what is the drug of choice? Let me explain perspective first. In India, most of the patients that we see with tuberculosis are quite symptomatic, malnourished, lean, thin. They have symptoms of tuberculosis and they have symptoms of diabetes. They need anabolism. In them, insulin will be the drug of choice. In the West, perhaps, I have no personal experience, perhaps tuberculosis is picked up early and those patients are not so catabolic. Maybe they have not lost so much weight and maybe they don't have too many symptoms of diabetes or TB. There we will follow standard care, standard guidelines, beginning with metformin. But here in India, if you have to treat a patient with tuberculosis, if your patient is hale and hearty, normal weight, then follow the normal guidelines. Do whatever you are doing. Use metformin, use gliptins, use sulfonylureas, SGLT2 inhibitors. Just be watchful for drug-drug interactions. We'll talk about that in a minute. And be watchful for appetite. With some drugs like vildagliptin, be watchful for hepatotoxicity. But otherwise, if your patient is weak and needs weight gain, then insulin is the only drug that we will use. When will we use insulin? In new patients with active tuberculosis, and an HbA1c more than 9 or a fasting more than 200 in new patients with active tuberculosis and ketonuria or hyperosmolar symptoms like polyuria, polydipsia, polyphagia will be very rare. Also, patients with active tuberculosis who are already on two oral drugs, metformin plus one more, but they have not reached glucose targets. They have not been able to control their glucose. Apart from all these, all patients with active tuberculosis who are catabolic, and all those with liver dysfunction or renal dysfunction. So you have a fair picture in your mind now. If your patient is otherwise healthy, apart from tuberculosis, think of oral drugs. If your patient has tuberculosis plus any other comorbidity or any other severe symptoms or ketonuria, or is already not controlled with 2 plus oral drugs, then do not delay in giving insulin. What regimen will we use? That will depend upon the patient. Basal bolus will be ideal. If you feel patient cannot tolerate, you can start premixed twice a day. In tuberculosis, it will be a good idea to give insulin analogs instead of human insulin. The reason is that analogs will cause less hypoglycemia. And in active tuberculosis, we are not too sure about the food intake, and we also cannot be too sure about food absorption because patient may have intestinal tuberculosis along with pulmonary TB. So, in most patients, we will start metformin. We will start insulin, which will be either basal bolus or premixed. But in some, we may wish to start metformin. The good thing about metformin is that it has an anti-tubercular effect as well. So it will help kill the mycobacteria. If the patient has mild hyperglycemia, we can give it. If the patient is eating well, we can give it. But if the patient is already calorie restricted, patient is not able to eat properly, then don't give that big tablet of 500 milligram. Once the patient has begun eating properly, you can always add it to an insulin regimen. Sulfonylureas are quite fast at achieving euglycemia. You can use the modern ones like glyclazide and glimepiride if the patient is otherwise stable. DPP-4 inhibitors, the advantage is there is minimal hypoglycemia, but you will have to check SGOT-PT frequently. So vildagliptin may not be a good drug to use. We can think of using linagliptin if we wish, along with metformin. Pioglitazone, again a good drug to use. It is safe for the liver. It will help fight insulin resistance and it will also help in weight gain. So you can begin 50 or 15 or 30 milligram once a day. SGLT2 inhibitors are also safe and you can use them selectively, but use them only if the patient's body weight is normal or overweight or obese. Do not use in underweight patients. Alpha glucose disinhibitors will cause a little bit of flatulence and gastritis, so it would not make sense to use them along with ATT. Apart from thinking about diabetes in tuberculosis and about tuberculosis in diabetes, we should also remember the complications of diabetes. So, persons with tuberculosis and persons on anti tubercular therapy, both, if they have diabetes, will have a greater risk of cardiovascular disease, a greater risk of renal disease, and a greater risk of hepatic dysfunction. So, do keep monitoring your patients clinically as well as biochemically. If your patient gives you a symptom of breathlessness, it can be due to the pulmonary involvement, but it can also be heart failure. It can also be ketoacidosis. So, if a person is taking ATT from the civil hospital next to you and comes to you with breathlessness, do check a urine ketone and do screen for heart failure. These are important points because you will find that many often the diagnosis is missed. Everyone is in his or her own tubular vision. The endocrinologist thinks only about glucose. The pulmonologist thinks only about tuberculosis, and it is the general physician who has to put everything together. So the responsibility is quite heavy on our shoulders. It sits very heavily, and we should fulfill that responsibility. So if a person comes with diabetes and TB, think about the rest of the patient as well. Also, remember that there is a triangle, a Bermuda triangle here is tuberculosis, diabetes, and HIV. So do think of HIV as well if you find an atypical situation. Of course, prevention is better than cure. So make sure that you prevent poorly controlled diabetes by preventing it in the first place, by managing it in the first place. And also prevent tuberculosis from worsening. Screen aggressively. Make sure that we are able to manage both tuberculosis um, and diabetes. And take this opportunity to encourage vaccination, BCG vaccination for all children, and COVID for all adolescents and all adults. So, to summarize today, we've spoken about something totally different. Instead of speaking about just glucose control, instead of speaking just about vascular complications, today we've talked of tuberculosis. Unfortunately, we are considered the tuberculosis capital of the world. But if we take this opportunity, if we catch this bull by the horns, we can actually make ourselves the tuberculosis capital, the tuberculosis care capital of the world. We are headed in the right direction because every time we see so many people answering the questions correctly. So the answers to last week's questions are: NAFLD confers a higher risk of hepatocellular carcinoma, yes; cardiovascular disease, yes; advanced liver disease, yes. But the answer was autoimmune hepatitis. NAFLD is not associated with autoimmune hepatitis. Rather, type 1 diabetes and autoimmune hepatitis go hand in hand. Our other question was, which of the following is a zero calorie sugar? And the answer is sucralose. Another correct answer would have been stevia. Let's come to our questions for this week, and they are related to the topic that we just discussed. Which of the following first line antibiotics uh, are usually not used in Mycobacterium tuberculosis? Mycobacterium tuberculosis is usually resistant to which of the following first line antibiotics? So let us see where this googly answer is, because both have to be correct. So the first is isoniazid and ciprofloxacin. The second is isoniazid and rifampin. The third is rifampin and ciprofloxacin. And the fourth is rifampin and streptomycin. So where is resistance most common with which pair? And the second question is, which is the only nutritive sweetener made from sucrose with unique properties? So the googly here is, this nutritive sweetener should be made from sucrose. And the choices are A. Sorbitol, B. Fructose, C. Sucralose, and D. Stevia. So let's repeat the question again. Which of these nutritive sweeteners is made from sucrose and has unique properties? The choices are sorbitol, fructose, sucralose, and stevia. I'd like to thank you for a patient listening, and let's go to the questions for today now. Dr. Hitesh Vora asks, how do we diagnose latent tuberculosis? Now, that is a good question. Uh, Honestly, Dr. Hitesh, I will not be able to give an accurate answer, but the screening tests would be an ESR, maybe a CRP, and also a chest X ray. Take a past history of tuberculosis. And if the patient has had tuberculosis in the past and now comes with uncontrolled diabetes, then you will keep latent TB at quite high in your index of clinical suspicion. Dr. Srimandir Kumar says, when a patient of diabetes under good control has developed COX and is on ATT, if the patient is under good control on tablets, we can continue the same tablets. But if the patient is not in good control and has developed tuberculosis, then insulin should be given. And we already explained the main decision will be based upon the phenotype of the patient and on the glycemic severity. Dr. Gigi Parmar asks, what are the points related to stress diabetes? So, anytime, whenever a patient develops physical stress or psychosocial stress, counter regulatory hormones come into play and glucose levels go up. Glucose and prolactin, these are the two endocrine parameters that will increase in everybody with stress. So whatever stress is there, glucose levels will go up. It is an adaptive mechanism. The glucose gives more energy to the body to fight the stress. So you will find many people who are admitted in ICU will also have hyperglycemia. But the moment you correct the underlying medical, surgical, obstetric, or psychosocial cause, the glucose levels come down. The management is based upon the glucose numbers. If glucose numbers are high, then you will give insulin as the patient is in ICU. And in the OPD, you can actually take a history. And if patient says, yes, I had gone through such and such a stress 3 or 6 months ago, and but now I am okay, things are fine now. So you say, yes, right now we are beginning medication because your HbA1c is 10. This is your glucose value. But we will keep on monitoring you every week, every 2 weeks. As the glucose and HbA1c come down, we will de-escalate therapy. Today, in fact, I had a patient a 35-year-old male, who came today with an HbA1c of 6.5. And just about 6 months ago, his HbA1c was 16.1, 16.1. We started with triple oral drugs that time. He had gone through severe mental stress at home. And today he came back smiling and happy, and we sent him on metformin 500 milligram BD. In him, I keep on checking HbA1c every 40 to 45 days because there is sudden fluctuation. Dr. Pramod asks about experience with tuberculosis and diabetes during COVID time. So, actually, in the initial part of COVID, tuberculosis patients in my OPD came down, perhaps because of the lockdown, and now they are coming back again. Overall, the number of catabolic patients in my OPD has gone down markedly over the past 20 years. 20 years ago, everybody with TB and DM was catabolic. We had to give basal bolus to everyone. Now, I think it would be around 50-50. 50% of the patients need insulin, 50% do very well with oral drugs. You can also tell your patient that we will give insulin only until required. That may be for the intensive phase of 4 drugs, it may be for 6 months. After that, as the tuberculosis improves, glycemic homeostasis will also improve, and we will be able to de escalate your therapy. Dr. Gangadhar Rath shares the case of a diabetic patient on OAD who has well controlled glucose, but urine sugar is positive. Maybe, sir, patient is taking SGLT2 inhibitor. So check the history. Patient might be taking Canna, DAPA, or empagliflozin. That would be the commonest reason. Second commonest would be familial glycosuria. So ask if there are other people in the family who have that. Dr. Madhuri Raghuvanshi says, is there any hereditary connection of diabetic tuberculosis? No, not genetic, Dr. Madhuri. Only that if people in the same family, they live in the same house, and if the house is not well ventilated, if there is close connection with each other, then they can get tuberculosis from each other. Uh, but that is because it is being spread through the air. That is why. CBNAT, Dr. Ashutosh Das raises a very good point, and CBNAT is being used in tuberculosis and in other diseases as well. If it is available in your district, you should go for it. And especially if, let us say, you have a very strong clinical suspicion of TB, but the sputum AFB is coming negative. Dr. Vishnu Mulchandani asks if any tuberculosis drugs cause hypoxia. The answer is no, or cause hyperglycemia. Well, yes, indirectly. Streptomycin can cause renal dysfunction. Almost all the drugs can cause hepatic dysfunction. And if you have a patient with hepatic or renal dysfunction, that will lead to increased glycemic variability. The books say that mostly we will get hypoglycemia, but sometimes in the acute stage, you will get hyperglycemia as well. When you give a drug like levofloxacin, that can interact with some of the glucose lowering drugs, and actually it can cause hypoglycemia. So these are some ways in which the TB drugs can interact with our glucose lowering therapy. We have other comments as well. And warm welcome to Dr. Anshul Singhai from Bhilai, who is doing a very good job there in spreading diabetes awareness. We also welcome Dr. Achan Khan from Rampur in Uttar Pradesh. Dr. Achan Khan also raises the point of CBNAT, and he says that CBNAT is available at PHC level. I think that is another good thing that the government is doing, and we should take advantage of this. The question from Chhattisgarh is SGLT2 inhibitor recommended in TB and type 2 diabetes? So now let us discuss why we want to give SGLT2 inhibitor. First, we want to give it for glucose control. So if patient is catabolic, we will not use SGLT2 inhibitor at all. we will prefer insulin. If patient is not in catabolic state, then there are other drugs that can be given, like metformin, sulfonylureas, gliptins. These can be used. If the patient has come out of the acute phase, patient is doing well, and then patient says, yes, I am relaxed now. Now I want better quality of life, quantity of life. Then we can start the SGLT2 inhibitor for um, CV protection. We avoid vildagliptin in TB and type 2 diabetes. That is correct, Dr. Anshul. It is a good idea to avoid because vildagliptin can act upon the liver. So why unnecessarily add a hepatotoxic drug? Linagliptin will be the safest if you want to give a gliptin. In type 2 diabetes, it is pulmonary tuberculosis which is the commonest, but lower limb involvement and diffuse involvement is more common. Also, atypical tuberculosis is more common in type 2 diabetes, and extra pulmonary tuberculosis like intestinal or endometrial uterine TB is quite common. I'd like to thank everybody who has logged in. Health issues are there. I think the entire country seems to be going through this Omicron kind of thing. So that is here at home also for me. But I think together, once we are able to speak with each other, connect with each other, that makes us feel stronger. You don't feel lonely anymore. So I'd like to thank everybody who has logged in today. Once again, we'll request everyone's opinion. We will be starting season 2 of Diabetes Essentials in mid March. So, the request is first of all, tell us what kind of topics you would want covered. And secondly, tell us what time of the day, of the week, what day and time of the week you would want this program to be held. Are you comfortable with Sunday nights or would you like a more earthly hour to discuss this in? So, with this, I'll take your leave and hand over back to the team from FDC and NRSL.
Thank you, sir. I think today's topic was very interesting, where you have shared when not to use uh, drugs orally, which we commonly see in prescriptions, especially today's catabolic and anabolic patients. Differentiation is very important when you are trying to treat TB as well as hypoglycemic episodes. With this, I thank Dr. Sanjay Kalra for guiding us because this was one topic where on a daily basis TB cases have been seen by the primary care physicians. With your experience of treating as a TB with endocrinology angle, now I'm sure that they have got the clear cut direction that which patients they have to use insulin, which not, which patient can be used with oral hypoglycemic agent, especially with newer drug when not to use. Thank you very much, sir. And obviously, as you have already shared that we will be very soon looking forward for the season 2. We look forward for more engaging opinion from all the viewers regarding the dates, the day, as well as the topics. With this, I thank you and Jai Hind, sir.
Jai Hind.